Okay, we are all set. Dr. Van Hise, if you want to just jump right in.
Yeah, thank you. Hi, everyone. I am so excited to be here today. My name is Dr. Katherine VanHise. I'm going to be speaking about fertility and pregnancy considerations in lupus. Thank you so much to Lupus LA for having me. A little bit about me. I am from Pennsylvania and got my medical degree from Penn State College of Medicine. I then moved across the country to Los Angeles and did my OBGYN residency at Cedars-Sinai and stayed there to complete my fellowship in reproductive endocrinology and infertility. So I'm an OBGYN, which was a 4-year training program, and then an REI or a fertility doctor, which was an additional 3 years. And now I'm out in practice. I work at HRC Fertility in Beverly Hills. I'll give you some info at the end of the talk. And I think also important to know, I'm a lupus patient myself, like many of you. I had my first symptoms show up about 3.5 years ago and was formally diagnosed with lupus about 2 years ago. And so this is obviously something that's very near and dear to my heart, and hopefully I can provide some valuable information for any other lupus patients out there that have some questions about reproductive health. Um, the outline for my talk, I want to first start with Fertility 101, since I am a fertility doctor. This is something that I love to talk about, so I will try and keep it brief. Then I want to talk about how lupus relates to fertility, review fertility treatments and their safety for lupus patients, and then finally conclude with lupus in pregnancy. So, Fertility 101. I think it's important that we start with the very basics. So, what is the anatomy of reproduction? The picture is a nice picture of the internal female reproductive organs. So, starting with the ovaries, that's where your eggs live and is the site of ovulation. The egg, when ovulated, moves down the fallopian tube, and that is where it is fertilized with sperm. The uterus is a muscle, and also where the embryo, that if the sperm and egg fertilize, will implant, and that's where you carry the pregnancy. The cervix is the very base of the uterus. That's what dilates while you're in labor. And then there's the vagina, which is the outflow tract. The sperm also deserve to be mentioned at this point. So the sperm get deposited in the vagina. They need to be able to swim up through the cervix, up through the uterus, and meet the ovary or meets the egg in the fallopian tube for conception to occur. Another really important thing that I talk about with my patients often is that timing is critical. So you're not likely to get pregnant on any given day of the month. It really is related to when that egg is released or ovulated. So the picture on the left is a graphic that shows those purple circles, which are the follicles. We say that follicles are what we can see and measure on ultrasound, and that one follicle should contain one egg. There's a lot of follicles that might show up at the beginning of the month, but only one of them is chosen to be the special follicle of the month that will go on to ovulate the egg. Most of the time, this occurs in a woman who has regular menstrual cycles at around cycle day 14. You can see the graph on the right shows that the clinical pregnancy probability from a single act of intercourse in a month, it varies significantly, and it's highest at right about day 13 or 14, with the highest likelihood of conception occurring the day prior to ovulation. I also think it's worth mentioning, and I review this with my patients, that reproduction is actually extremely inefficient. So this graph shows the per month chance of getting pregnant on your own, natural conception, based on your age in years. So in our peak ages of fertility, so low 20s, it's about 25%. And you look at about 30 to 35, it's gone down quite significantly already to be about 15 to 20%. And if you're looking over the age of 40 or 43, we're at about like 5%, and then it continues to dwindle off. This is per month. A large part of why reproduction is inefficient is because of the ovarian reserve. Not to say that this is all the fault of the ovaries or the eggs. It's a large contribution from male and female factor, and I'll review different etiologies of infertility. But the unfortunate reality is that the ovarian reserve doesn't get any better with age. So women are born with all of the eggs that they will ever have. This is different than in men. Men continue to make sperm throughout their lifetime, but women, we actually have our most number of eggs in utero. So when we're about second trimester fetuses is when our ovaries contain the most number of eggs. By the time we're born, we've already lost millions of eggs just through a natural process where some of them die off, what we call atresia. So at birth, you have about 1 to 2 million eggs. They continue to decline, and so that when you reach puberty, when you start having your menstrual cycle, there's only about 3 to 500,000 eggs. And with each month, a certain cohort of those eggs or those follicles are selected. As I mentioned, there are those little ones that we see at the beginning of the menstrual cycle, and one of them goes on to be chosen. And you lose that cohort every month. And so that's something that then leads to the ultimate decline of all of the follicles or eggs in the ovaries, and that's what we call menopause. Ovarian reserve does decline, like I said, from puberty to menopause, but we really see a marked decline in the mid-30s. The graph on the left shows just childbearing. So in women that are not using reproductive technology like IVF, we see a decline, particularly around and after age 35. And the graph on the right shows a similar trend. However, this is data live baby per egg with IVF by age. So same thing, there's a marked decline in the mid-30s, significantly after 35. So the number of eggs goes down, but the quality of the eggs also goes down. And that's something that this graph on the right is really reflecting. So even with IVF, when we've retained an egg, it might not have the best quality to be the potential for a live birth for a baby. I wanted to touch on the definitions of infertility. So the sort of traditional textbook definition is failure to conceive after 12 months of regular unprotected intercourse in individuals that are under 35 years of age, or failure to conceive after 6 months of regular unprotected intercourse if you're 35 or older, or if you have a known medical condition causing infertility. There was a more updated definition that the ASRM, which is our American Society for Reproductive Medicine, so our like national group, put out in 2023 that was meant to be more inclusive. And it is as follows: the inability to achieve a successful pregnancy based on a patient's medical, sexual, and reproductive history, age, physical findings, diagnostic testing, or combination thereof. Or if you need medical intervention, such as the use of donor gametes or donor embryos to achieve pregnancy, either as an individual or with a partner. So this expands the definition of infertility sort of beyond that just like traditional definition that was referring to heterosexual couples having intercourse. So now the use of a donor egg or a donor sperm as an individual, or if you have a partner, all constitute the definition of infertility. The most recent quote from the WHO is that 1 in 6 people experience infertility in their lifetime, which is pretty prevalent. I do think that there's been more attention in the media and just people have begun to talk about it a little bit more. So it might feel as though there's a lot more people speaking about their infertility, but 1 in 6 is still pretty significantly high. Reasons as to why we might have infertility are several. They're listed here. Ovulatory dysfunction can refer to that decline in the ovaries with the egg quality and quantity going down, like I mentioned. It also could refer to if you're not ovulating each month. So that one picture I showed in the beginning where those purple circles were getting bigger and then one of them ovulates an egg. If you're not ovulating an egg, you're not going to be able to get pregnant. And this is something that we see sometimes in patients that have polycystic ovary syndrome or irregular menstrual cycles. Tubal factor relates to if there's any damage to the fallopian tubes such that the egg and the sperm can't meet there to pass into the uterus. Uterine factor could relate to some things like polyps or fibroids, a variety of different things that would impede implantation of the pregnancy. Male factor would be related to the sperm. And then obviously multifactorial, which is probably what I see the most with my patients, or unexplained. So that was my fertility 101. And now I wanted to relate that to lupus in particular. So I wanted to start out with some positive news. So pregnancy and conceiving a pregnancy is feasible for most lupus patients. However, there were these studies that I found that showed that women with lupus continue to have fewer children compared to those without lupus. One of the studies I think said it was like 64% of women with lupus ended up with a smaller family size than they would have intentionally or previously had wanted. That's just one small study, but I do think it's worth talking about the many factors that might go into why lupus patients might have fewer children compared to the general population. So again, I don't want to just sound like a broken record, but advancing maternal age is a big factor. A lot of lupus patients are diagnosed in their reproductive age. Um, Patients may opt to delay trying to get pregnant due to disease activity, or if they are still in the process of determining their diagnosis, or if they are diagnosed and they're using a medication that is not compatible with pregnancy, they may defer getting pregnant until they're in a more stable disease state where they can come off of that medication. There's something else that I had wanted to share that I had read that women with lupus are more prone to develop what we call diminished ovarian reserve or premature ovarian sufficiency than in the general population. So diminished ovarian reserve is a term that we use in our fertility clinics, and it refers to women that are still getting menstrual cycles, but that when we look with our measures of ovarian reserve markers, so counting the number of follicles, their AMH level, um, they might be lower than somebody that's their age, that's a counterpart. And premature ovarian insufficiency is essentially like lack of ovarian tissue function or like a premature menopause. This occurs when a patient is under 40 years of age, and we do some blood work that will show us that the brain is working really hard to stimulate the ovaries, but the ovaries are just not responding. So those both have been shown to be more prevalent in women with lupus than women without lupus. Other factors contributing to fertility in lupus patients is disease activity. So there were a few studies that I found that found a negative correlation between ovarian reserve markers and SLE disease activity index and the ESR, and also to cumulative organ damage in another study. And then I had read that lower AMH levels, which is a marker of that ovarian reserve, can occur independently of cyclophosphamide, which I'll talk about on one of the next few slides, but the data is mixed. So I think that's a common question, like, is my AMH lower just because I have lupus? The data is mixed. This was a nice review table that I wanted to pull from this paper from 2022, put out in the Lupus Foundation of America's journal. But you can see that the number of patients in these studies is really small. So only like 20 to 70 or 80 patients per study. We don't have any large randomized control trials or anything to look back at this, but the data is mixed. Some studies found that there were no differences between lupus and non-lupus patients in terms of their ovarian reserve, and some patients found, or some studies found that there were significantly different values, with lupus patients tending to have lower AMH values than non-lupus patients. And this is in non-cyclophosphamide treated patients. So I think the jury's still out. My clinical sort of feeling on it is that it's probably more likely that lupus patients are going to have diminished ovarian reserve in these lower numbers. But there's a lot of contributing factors, and everything is sort of an individualized patient assessment. Cyclophosphamide, however, or cytoxan is the brand name, is well known to contribute to ovarian like failure, diminished ovarian reserve, premature ovarian insufficiency. So this medication works. It interferes with oogenesis, which is the ovaries with the eggs and the follicles growing each month, and spermatogenesis. So in women, like I said, it can cause DOR, the premature ovarian insufficiency. In men, we see what we call azoospermia, or zero sperm count, or oligospermia, so low sperm counts. So it is toxic to both the gonads of both men and women. The impact is unfortunately cumulative and irreversible. And the risk for toxicity goes up with the age at which you're receiving the medication and the total cumulative dose. So the number that I had read in the literature is a total cumulative dose over 7.5 grams per meter squared is much more likely to cause sort of this reproductive failure or an inability to return to reproductive function than if you were getting a total cumulative dose less than 7.5. I had read a study that said for age, women that were over 25 were much more likely, I think 2 or 3 times more likely to have irreversible toxicity from their cyclophosphamide than if they were younger than 25. We don't, I mean, I'm not a rheumatologist, but my understanding is that we don't use this necessarily first line as much as we used to, which is a good thing. I do know that in the lupus literature, there has been exciting advancements with the use of CAR T cell therapy. And my understanding is that cyclophosphamide can be used as part of the pre-treatment to CAR T cells. I did look up what the normal dosages were used for cyclophosphamide in the cancer literature. And the doses are much, much lower than the 7.5 grams per meter squared. And my understanding is that it's like a one-time dose to deplete all the lymphocytes prior to doing the CAR T cell therapy. So if a lupus patient is planning or considering CAR T cell therapy, I would say it is less likely that the use of cyclophosphamide for a one-time dose is going to negatively impact the ovarian reserve because the dosage is much less. Other medications that we use commonly in lupus can impact fertility. So either directly or indirectly, but corticosteroids, prolonged use, as we know from steroids, can contribute to obesity, adiposity, and metabolic syndrome. Adipose tissue, so fat, has an enzyme aromatase that produces estrogen. So this can lead to having high estrogen levels in women that have adipose tissue or obesity. The estrogen levels then tell your brain, oh, you don't need to signal to the ovaries to make any more estrogen. You already have a lot of estrogen. So we call that HPA or HPO axis dysfunction. So basically, the ovaries are not necessarily ovulating like they normally would be because the brain is receiving signals that it doesn't need to produce the hormones necessary to ovulate. And in women, this can lead to anovulation. In men, this can lead to lower testosterone. Another medication that a lot of lupus patients are familiar with, NSAIDs, so like your Advil, your ibuprofen, et cetera, and high dose aspirin. I read like over 2.6 grams per day. So not like the baby aspirin, which is the 81 milligrams, but high dose aspirin. These work and can temporarily and reversibly affect ovulation in women and can cause reduced sperm count, sperm motility, and testosterone production in men. Just their mechanism of action as COX inhibitors is that they impair that prostaglandin release. And so the ovulation is impacted in women where the follicle might grow to be ready to release an egg, but the egg just doesn't release, so you can't get pregnant. So I would say that if you are trying to conceive and you're using NSAIDs routinely for pain, if you know that you have regular cycles, maybe discontinuing for just a few days around that time of ovulation. I had read that it was very short-lived, the impact for women. For men, it can take, I think, a few weeks for a few months to change the sperm counts. Other contributing factors for fertility in lupus patients: pain, fatigue, can reduce your frequency of intercourse. I read that men with lupus are more likely to have erectile dysfunction than the general population. And then autoantibodies, which I think is a big topic. So antiphospholipid antibodies I'll talk about in terms of treatment and recommendations from our societies on that. But antiphospholipid antibodies are associated with recurrent pregnancy loss. Other antibodies like antithyroid antibodies or other anti-reproductive organ antibodies, like there's anti-ovarian type antibodies, can contribute to premature ovarian insufficiency. So when we are working up premature ovarian insufficiency in patients, we'll order a whole panel of antibodies in all of our patients to see if there's any autoimmune cause. And then lastly, I wanted to make a point. I had read some papers that were suggesting that positive ANA in and of itself might be linked to infertility, but I think the data in general suggests that infertility in positive ANA only patients is likely coming from an undiagnosed autoimmune disorder rather than the positive ANA itself. This is just a reference table. You can take a screenshot or come back to this in the YouTube presentation, but it summarized it all pretty nicely. And then I wanted to move on to fertility treatments, which is the bread and butter of my clinical practice. And I'll review them just for general knowledge and then talk about specifically with lupus, any considerations and safety. So fertility testing, I've alluded to this a lot earlier already in the presentation, but you come into the fertility clinic, one of the first things we're going to want to do is do some sort of testing. So this antral follicle count that I've mentioned, those small resting follicles that we think have the potential to grow a mature egg, we can count them on ultrasound. So this picture on the right is a transvaginal ultrasound image of an ovary. The pink arrow is pointing to a black circle. That black circle is what we consider a follicle. I'll show in some subsequent slides that we would watch that grow, and one follicle could contain one egg. Anti-Müllerian hormone is a blood test, AMH. This can be done at any point in your menstrual cycle. There's some other hormone levels that we check at specific times in the cycle, and AMH is done at any time. Other fertility type testing, we evaluate the fallopian tubes, we evaluate the uterus, and we do a semen analysis. So sort of checking off all of the different causes of infertility so that we know exactly what's going on. Depending upon what the fertility testing shows, there's many different treatment options. Some are much more or much less invasive or time consuming than others. So I'll go through all of them and then show some pictures. But timed intercourse and intrauterine insemination, I would say, are the least invasive treatment options. Timed intercourse is simply knowing when you're ovulating and having intercourse at the time that best correlates to pregnancy success. That can be done that we help you grow an egg and watch it and grow an ultrasound and then tell you when to have intercourse, or you could be doing this at home with ovulation predictor kits. Intrauterine insemination is a procedure that we do in the clinic. You're not needing any sort of anesthesia. It's like a pap smear. We place the best moving sperm directly into the uterus so that it has the highest likelihood of meeting that egg and resulting in a pregnancy. IVF and embryo transfer I'll review in detail. Third-party reproduction I'll also review in detail. And then fertility preservation. So this is something that's becoming much more talked about in the news and the media. So egg freezing or embryo freezing. So I will review those as well. But embryo freezing is essentially the same process as IVF, just without the embryo transfer. Egg freezing is growing all of the eggs, but not fertilizing them. So it's like the female part of IVF, but we don't actually fertilize the eggs. But starting with the first few. So what we consider controlled ovarian stimulation is when we help you grow one of those follicles or two of those follicles to be big. So that's what the photo on the right is showing, two follicles after the administration of oral medications that you take grow to be large enough to contain a mature egg. And then we can monitor this in the clinic and tell you exactly when you're going to ovulate, or we can make you ovulate and time it with intercourse or that IUI procedure. So this is something that's much less invasive. If any shot, it would just be one subcutaneous injection just once to help trigger those eggs to be released. But generally, just oral medications are involved. IVF or egg freezing is a much more time-intensive process. So it's about 10 to 14 days of hormone injections. You're giving yourself about three injections per day. They help the follicles grow. You can see the difference in this picture on the right. Instead of growing just one or two follicles, we're trying to make all of them grow to contain mature eggs so that when we do the egg retrieval, we can get as many eggs as possible. So this requires at-home injections. There's small subcutaneous needles, and then monitoring in the office with blood work and ultrasound about every 2 to 3 days. So we do see our patients quite a bit during that time, which is nice. Leading up to that, your ovaries get enlarged, you're growing the follicles, and then we move forward with an egg retrieval. The picture from the textbook on the left shows what that looks like, but it's very similar to what we do in the office every time I see you. So a transvaginal ultrasound, I can see exactly what I need to see in the ovaries, except for now in the procedure itself, there's a needle that goes into the follicles to drain that follicle fluid, which should contain an egg. This procedure is done here in the clinic in our surgery center that's connected to the IVF lab. You do get anesthesia through the IV, so you're not getting like a breathing tube down your mouth. And the procedure itself lasts about 15 to 30 minutes. Most patients wake up, feel fantastic, go home, and only just need oral medication at home, Tylenol, maybe Motrin. I would say the majority of my patients feel much improved back to normal the very next day. And yeah, I think happy to answer any other questions about egg retrievals. But in the lab, if you're just doing egg freezing on the day of the egg retrieval, the eggs are frozen, and that's the picture on the left. So the eggs get frozen in liquid nitrogen tanks, so they can stay there indefinitely. If you come back to use them, we thaw them. Or if you're making embryos or doing IVF, on the day of the egg retrieval, the egg is fertilized with sperm, and then we grow embryos. So these are pictures, both cute cartoons and real pictures of what embryo development looks like. So the bottom left, a mature egg. Then you can maybe appreciate the fertilized egg. There's those two little circles. That means it's fertilized. They go on to cleave from 2 cells to 4 cells to 8 cells. That's called a cleavage stage embryo. And then eventually they become a blastocyst stage embryo, which is hundreds of cells. This usually we want to see it between 5 to 7 days after your egg retrieval. And it allows us to do what we consider pre-implantation genetic testing, or PGT, where the embryologist can take a small biopsy of just a few cells of that blastocyst embryo to test for genetic tissue. So it tells us, do you have a normal number of chromosomes? We also can know if that embryo is going to be a male or a female. And if there's specific genetic mutations that we're screening for, you're able to do that as well. So that's the technology of IVF. The embryo transfer itself, once we have made and grown embryos, is much less invasive than the IVF stimulation. The embryo transfer occurs here in the office. I would say it's, again, similar to like an IUI or a pap smear, basically in the office procedure, no anesthesia. We transfer an embryo directly into the uterine cavity under ultrasound guidance, and then our patients go back to work or life or activities the same day. There's no advised activity restriction. Third-party reproduction, I think, is something that is really important to talk about. So there's many different ways that you can build a family. You can use donor eggs, donor sperm. You can use a gestational carrier, or that's sometimes referred to as a surrogate. So with donor eggs, you could do IVF. With donor sperm, you could do an IUI or IVF. A gestational carrier or surrogate, you could use with either a combination of your egg plus donor sperm, or you could use your egg plus partner sperm and then put that in a gestational carrier. So there's a lot of different ways that third-party reproduction can be utilized, and it's really individualized per patient with what their need may be. So a question I think is really relevant for this talk, obviously, is the safety of these ART, or artificial reproductive technologies, in lupus. And the American College of Rheumatology has this fantastic guideline. I'll have several screenshots from it for you to reference. But they, in 2020, put out these guidelines for all reproductive health in rheumatic musculoskeletal diseases. And then they do make specific recommendations for lupus at different points that I'll bring up. But in general, the ACR and all of our OBGYN and fertility doctor guidelines say that lupus should be well controlled prior to trying to conceive, or even pursuing fertility treatments, ideally for 6+ months. So if you're coming to me and you want to get pregnant, then we also need to make sure that you're already on pregnancy compatible medications and doing well for about at least 6 months. If you're just planning to freeze eggs and not get pregnant in the near future, then you don't necessarily need to be on pregnancy compatible medications, and I'll speak to that a little bit later. The guidelines do point out that in patients with lupus, there's this concern that the ovarian stimulation will lead to elevated estrogen, which may worsen active disease. So those pictures that I showed you of the follicles growing, so either with the oral medication or the injectable medications, the ovaries get really big as the follicles grow. Those follicles are making estrogen levels, or making estrogen. So your estrogen levels get really high, sometimes during IVF in particular. In a normal menstrual cycle, your estrogen might peak at about 500-600. With IVF, we can see that be in the thousands. So it's substantially higher than just in an average month. And there's this thought that estrogen can impact the different immune system, B cells, T cells, et cetera, the signature, and that it might trigger a flare. So the guidelines say that we recommend deferring any of these procedures if you have moderately or severely active disease. But this recommendation is just extrapolated from the disease activity increasing with pregnancy. We don't have a lot of great studies specifically about fertility treatment and lupus and estrogen levels, but we're extrapolating from what we do know from pregnancy. They also make a statement that in patients who have stable disease, desire pregnancy, and have positive antiphospholipids, or are diagnosed with antiphospholipid syndrome, they do recommend anticoagulation along with the fertility treatments. And this is because higher estrogen levels impact the coagulation factors that are made by the liver. And so you're more likely to have blood clots or thromboembolic disease with high estrogen levels. And the risk of bleeding from being on anticoagulant, we think, is a lower risk of bleeding than having a clot. And so we recommend being on anticoagulation if you have positive antiphospholipid antibodies, which is summarized very nicely. I like this flow sheet a lot. So this is from the ACR guidelines, assuming a patient is in remission or has stable low-level disease. They recommend assessing for antiphospholipids and antiphospholipid syndrome. If you have none of the antiphospholipids, so lupus anticoagulant, beta-2 glycoprotein, what's the third one that I'm missing? If you have any of those, you can do not have any of those, proceed with your treatment as needed without needing any sort of anticoagulation. If you have the positive antibodies but don't have the full clinical syndrome, they still recommend using prophylactic Lovenox or heparin during fertility treatment. OB, APS, and thrombotic APS are different categories of antiphospholipid syndrome. So the OB one refers to having the antibodies plus having a history of poor obstetric outcomes, like 3 recurrent miscarriages less than 10 weeks, a baby that's born early because of preeclampsia, things like that. And thrombotic antiphospholipid syndrome is having the antibodies plus having had a history of like a blood clot in your vein or an artery. And so for those, they have their recommendations that are listed there. They also recommend in this flow sheet that I just showed that they recommend continuation of necessary immunosuppressive and or biologic therapies during egg stimulation and retrieval for egg or embryo cryopreservation. So if you're not attempting to get pregnant now, but just want to preserve fertility with egg or embryo freezing for the future, the American College of Rheumatology recommends continuing all medications except for cyclophosphamide, which we know can negatively impact the maturing follicles. This even includes continuing mycophenolate and methotrexate, because we just don't want you to have the risk of flaring by coming off of your medications just for egg or embryo freezing. They also make a point in their guideline that prior to cyclophosphamide treatment, that in women who are post-puberty but premenopause, so still getting regular menstrual cycles, that GnRH agonists, what we call Lupron is the brand name most commonly used, should be administered to patients if they are not able or not interested in doing egg freezing. This medication works to essentially shut down the whole axis. So it should keep the ovaries as quiet as they possibly can be to help mitigate as much risk of the cyclophosphamide causing ovarian toxicity as possible. In men, sperm cryopreservation is best practice, and the ACR says that they recommend against testosterone co-therapy with the cyclophosphamide because that in and of itself will not preserve fertility. So really, this is a situation where a man might want to consider freezing sperm, which is much less invasive, much less expensive than egg freezing, and is something that can be done much quicker as well. So you could freeze sperm, have it in the future if needed. So just a quick review of the treatment options I discussed. There's the time intercourse, intrauterine insemination. Both of those, the estrogen levels don't typically get very, very high as we see with in vitro fertilization. So those would be like a less riskier, less invasive treatment. IVF and embryo transfer is something that requires a lot of frequent monitoring in the clinic and requires a lot of considerations of medications and whether you may or may not need that anticoagulation. Third-party reproduction would be if you choose or need to use donor eggs, donor sperm, donor embryos, or if you are a patient with lupus where your rheumatologist and I might feel like, yes, you're safe to make embryos, so you're safe to go through the IVF process, but perhaps you're not the best person to carry the pregnancy out of risk or concern for yourself. You could make your own embryos with you and your partner and then transfer them into a gestational carrier for the pregnancy. And then lastly, fertility preservation would be egg or embryo freezing or the use of that Lupron if necessary during cyclophosphamide treatment. Just like a very quick bulleted points for things to take home message, talk with your fertility doctor, rheumatologist, care team about. So you're thinking about going through treatment, assess your disease activity and your comorbidities. So is now the best time to get pregnant or pursue pregnancy? And is pregnancy the safest option for you? So there's certain conditions, pulmonary hypertension, very severe restrictive pulmonary disease, severe renal or kidney involvement, it might not be recommended from your rheumatologist or your OBGYN to conceive just out of the concern for your own health and safety during pregnancy. So those are things to think about. I've mentioned a lot these antiphospholipid antibodies. So if you have lupus, make sure that your rheumatologist or your fertility doctor or OBGYN has assessed to see if you have the antiphospholipid antibodies so that we know if you're going to be going through treatment like IVF, do we need to give you medication to prevent blood clots? And I wrote down here, is it prophylactic? Is it therapeutic dosing? For how long? I would say in my practice, if somebody's on medication during their IVF stimulation, they take it for those 2 weeks that they're doing the injections to grow the follicles, hold it temporarily just for 1 or 2 days prior to the egg retrieval, resume it after the egg retrieval, and then be on it for another 10 to 14 days until you get your next period. At that point, then the estrogen level is low, so we're not concerned about the clot risk. And then lastly, I haven't touched on this yet, I don't think, the concern for ovarian hyperstimulation syndrome, which is that bottom right picture. So in IVF in particular, sometimes if the ovaries get really big, you have a lot of follicles, you can be at risk for what we call OHSS. In lupus patients, there have been a few case reports that this might exacerbate or cause flare or lupus nephritis. The pathophysiology of OHSS essentially is that your capillaries, your blood vessels are really leaky. So you leak fluid into your belly, into your pelvis. That's what that picture is showing. You can get a lot of swelling and that causes dehydration of your blood vessels. And so there might be some strain on the kidneys. This now in the age of ART and what we do is very rare to have severe OHSS in our patients. We have a lot of good ways to mitigate that risk and that Lupron trigger. So if you're seeing a fertility doctor, you can refer back to this slide so you know all the lingo, but a Lupron trigger is the most common and our best method to prevent OHSS and something that I think you can use to advocate for yourself as a lupus patient if you're going through fertility treatment. And then let's say you get pregnant, either with or without my help. We can talk a little bit about pregnancy. I think the biggest take-home message is that preconception planning is key. So for a healthy pregnancy, as minimal risks as possible, it's really important to involve your OBGYN, your rheumatologist from the beginning, bring it up in your routine visits. I'm thinking about getting pregnant. What do you think? Your OBGYN might refer you to a maternal fetal medicine or an MFM specialist. Those are OBGYNs who go on to do another 3 years of training, specializing in high-risk pregnancies and fetal conditions. And they'll be monitoring you closely throughout the pregnancy as well. Between the OBGYN, MFM, and rheumatologist, prior to getting pregnant, we want to make sure you're on all the right meds. If you're on any meds that are incompatible with pregnancy, try and taper them off, start something new, and make sure that you're stable so that we help prevent any flares. And also prior to pregnancy, we want to have baseline vitals, so blood pressure, weight, your labs, just like the normal baseline sort of lupus labs, including like your urine values. Make sure that you don't have any protein in your urine because that might be important later on in pregnancy to compare back to. And if you don't have the antiphospholipid antibodies already done, that's something that your OBGYN or rheumatologist might want to consider. And then these anti-Ro or SSA or anti-Law SSB antibodies become really important when we talk about the risk of neonatal lupus and having these antibodies actually cross the placenta, potentially contributing to the neonatal lupus, which we get concerned there could be a heart block, which I'll talk about. So having all these baseline labs and knowledge is really important just for pregnancy planning. I pulled these tables from this 2020 ACR guideline because I think it's really just fantastic. I don't think I could summarize it any better. But they break down medications. This is for women. I'll show you this slide on the next slide. And then again, for men, a separate table for preconception, during pregnancy, and then in women also for breastfeeding. So the green obviously means that's okay. The darker green with the 2+ signs mean, yes, this is very safe. And then the ones that are the lighter green, they have their notes for different considerations. But basically, hydroxychloroquine or Plaquenil is not only safe, it's recommended to be on in pregnancy. Sulfalazine, colchicine, azathioprine, all safe during pregnancy. Prednisone or steroids, trying to taper them down prior to and during pregnancy if possible. I'll comment on the NSAIDs, so those non-steroidal, Advil, ibuprofen, etc. I mentioned earlier that sometimes that can impede ovulation. So if you're having trouble conceiving, you might want to discontinue that just around the time of your mid-cycle, like cycle day 12 through 14. In pregnancy, we say avoid like Advil, NSAIDs. That risk is particularly important in the 3rd trimester. So it might be an individualized decision that you and your OB and your rheumatologist make if you're using NSAIDs, that it could be safe to continue in the 1st and 2nd trimester, but we do recommend discontinuing that for sure in the 3rd trimester. The TNF inhibitors, generally considered safe in pregnancy. This is the second half of that table. So for women, that they say are not compatible with pregnancy, and you can see those listed there. I won't read into all of those. And then I also really liked this guideline because it lists for men. So for men that have rheumatic disease who are planning to father a child, strongly recommend continuing, discontinuing, etc. And then they give you some guidance in terms of for how long you should be discontinuing, like a cyclophosphamide, at least 3 months prior to trying to conceive. The sulfalazine, you might want to stop prior to a semen analysis, or if you have an abnormal semen analysis, to stop it and then retest. Once pregnant, I love these guidelines. I keep pulling these figures, but the ACR recommends for lupus patients, continue hydroxychloroquine if you're already on it. Start it if you're not already on it. The ACR and all of our OBGYN societies all recommend for lupus patients to be on a low dose aspirin, ideally starting by 12 weeks. So that's like the end of your 1st trimester. For sure, we want you to be on baby aspirin. And then the ACR recommends labs at least once per trimester. They also in this table stratify based on if you have those anti-SSA, SSB antibodies, and if you have the positive antiphospholipid antibodies. If you have antiphospholipid syndrome, they recommend, as do the OB societies, that in addition to the baby aspirin, that you take a different anticoagulant to help prevent any adverse pregnancy outcomes. So for all patients with lupus, you should expect serial blood pressure monitoring. That's true for anyone that's pregnant, but in lupus in particular, at each visit and at home, checking your blood pressure, checking your labs, like the ACR recommended each trimester, check your blood counts, the CBC, the urine to make sure there's no protein in the urine, and then markers of disease activity, so the anti-double-stranded DNA and the complement levels C3 and C4. For all lupus patients, we recommend serial growth ultrasounds and antenatal testing. So this is generally done by that MFM specialist. They measure the baby. They do different tests to assess for the baby's well-being, listening to the baby's heartbeat with a non-stress test. And that starts generally in the 3rd trimester, so by 28 or 32 weeks, and is individualized from there, or maybe earlier if there's any findings that they're concerned about. And then if a lupus patient is also positive for these SSA or SSB antibodies, we recommend doing fetal echocardiograms, so a special different ultrasound done in the clinic where they watch the baby's heartbeat and heart muscle in particular to help see if we can identify any potential concern for the neonatal lupus and heart block. And that's done weekly in the 2nd trimester from 16 to 26 weeks. last but not least, obviously, are the risks of lupus in pregnancy. So I mentioned like preconception planning is key. Most lupus patients do very well. A lot of lupus patients might actually say they feel better. The different hormones, the estrogen, the progesterone, shift sort of the immune response. And so some women feel better in pregnancy, and some women might feel more of a flare after pregnancy. But in pregnancy itself, there are risks inherently coming from the lupus. So a risk of flare, like I said, overall mild to moderate in most, but there is a more increased risk of flare in the postpartum period. Lupus patients are at risk for lupus nephritis flare in pregnancy, particularly if you have underlying kidney disease or if you've had lupus nephritis before. Lupus patients are at risk for pregnancy-related hypertension. We call that preeclampsia, or in its worst form, eclampsia, a seizure. Lupus patients are at risk for having thromboembolism, so that's a blood clot during pregnancy. And then just in general, we're concerned about morbidity and your well-being, and very rarely maternal death. But that's very rare. You're plugged in with care. Most patients, like I said, do very well. Fetal and neonatal risks that we think about. Patients with lupus are at higher risk for preterm birth, whether that's just spontaneously going into labor early, so under 37 weeks, or if we say, hey, your baby's not growing well, we need to deliver early, that would be a medically indicated preterm birth. That's the second bullet point. So lupus patients are at risk of growing small babies. So that's fetal growth restriction while they're still inside, and then when they're born, small for gestational age infant. Lupus patients are at increased risk for miscarriage or stillbirth. That is in part due to that antiphospholipid syndrome, but also even without the antiphospholipid antibodies, there's an increased risk of loss. And then I've mentioned that the risk for the neonatal lupus or heart block if mom has those SSA or SSB antibodies, which can cross the placenta and impact the baby. But ending on a positive note, with good pre-pregnancy disease control, multidisciplinary care, most lupus pregnancies have a really good outcome. These are the references that I've referred to several times if you're interested in looking them up. So there's the 2020 American College of Rheumatology guideline where most of those figures were from. This Moyer and Eden's review is a very long but really thorough review considering infertility, fertility preservation, and pregnancy. And then the SMFN is one of our OBGYN sort of guidelines. These are those high-risk OBs and their statement on managing lupus and pregnancy. I really liked this table from one of those papers that just was like breaking it down, ART terminology. I know that with OBGYN in particular and infertility, there's a lot of acronyms. So these are some of the things I've mentioned you can refer back to for definitions. And then I just wanted, I'm kind of off camera. Just wanted to say thank you so much. This was such an honor. I'm so grateful to be here. I'd love to meet you, hear your story. There's a little time for questions now. If you want to come see me in person, this is our brand new office right at the Golden Triangle in Beverly Hills. You can scan the QR code for a link to my website, the card. The 866 number is to schedule any new patient appointments. I'm taking new patient appointments. Would be honored to meet you and hear your story. And I think that's it. So I can end my sharing for any questions.
Absolutely. Thank you, first of all, so much for that, Dr. VanHise. Thank you for laying out the whole Fertility 101, the treatment options, and we do have some questions, some of which you addressed already and touched on a little bit. So we'll do a few that are coming in right now. And if you want to unshare your screen, then we might be able to see you a little bit more clearly for the Q&A.
Oh gosh. Did I not figure out how to do that on my screen? Share.
You might be able to just end sharing. Let me see if I can change that. There we go. Perfect.
Did you end it for me?
Yep.
Thank you.
Great. Okay, let's start here. You sort of already covered this a little bit, but someone asked if I've had active flare in the last 6 to 12 months, when is the safest time to try starting to conceive?
I would say if you're now on a dose of medications that your rheumatologist feels as though you're stable on, so you have not had a flare, at least we want at least 6 months of being on pregnancy safe medications without a flare.
Okay, perfect. We have another question here asking about what medications are lupus safe during pregnancy and which ones you need to stop or change ahead of time. But you had that really amazing slide in there.
Yes.
That chart was so helpful. So thank you for that, where you kind of outlined all of those options. So if that was your question, feel free to just scroll right back to that really amazing chart, unless you have anything to add to that one, Dr. Van Hise.
No, I would defer to the chart.
Perfect.
Plaquenil for all.
Yeah. Um, and then, is it true that ovarian reserve can be affected in lupus? And should you freeze your eggs early before you're ready to get pregnant if you have lupus?
Yeah, I had shown that one table. So the data is mixed, although I do feel like most likely, especially if you've had severe disease with like organ damage or you have like, high active disease now, your ovarian reserve is likely to be impacted. Um, but the data has shown it both ways. I think I'm just an advocate in general. If you have the interest and the means to do egg freezing just to help prevent anything in the future, you're doing what you can now for future fertility planning. So I'm an advocate for all women, but certainly if you have lupus, I think it's something to consider.
That makes sense. If I've had lupus kidney involvement, how can you determine if pregnancy is a risk or how much higher the risk might be?
I would, from my knowledge in fertility medicine and having done OBGYN residency, knowing that you've had kidney involvement before does increase your risk of kidney involvement or other complications in pregnancy. So that would be lupus nephritis recurring, or in pregnancy, we also really worry about it's called preeclampsia, which can impact the kidneys. But the exact percentages and your individualized situation, I would review that with your rheumatologist and then perhaps see a MFM, that high risk OB doctor for a preconception planning consult.
Yes. Should I still plan for breastfeeding? Are there lupus treatments compatible with breastfeeding, or does having lupus make breastfeeding more complicated?
You can still breastfeed, but refer back to that chart. There were different ones that they said were safe in breastfeeding versus not in breastfeeding. So, in terms of the medications itself, I would refer back to that chart that I had listed.
Okay. And we'll take two more. You touched on this a bit already, but does lupus reduce my ability to conceive, or is infertility associated with lupus more linked to the treatments of lupus?
The treatments of lupus with the cyclophosphamide definitely known to contribute to infertility. Lupus itself, I didn't find any compelling great data set that said, yes, if you have lupus, you're more likely than that 1 in 6 individual to have infertility. But there's just so many factors involved with a lupus diagnosis that I went through that could contribute to subfertility or maybe some trouble getting pregnant.
Okay. And then we'll take the last question. For those of us who have had prior miscarriages and have lupus, what specific additional monitoring or intervention should we ask for when planning another pregnancy?
If your team hasn't already worked up that antiphospholipid syndrome, I would recommend that you bring that up with your care team. So either rheumatology or OB, especially if you've had multiple miscarriages. And then that can help guide if in future pregnancies they would recommend something more than just a baby aspirin. If you do have antiphospholipid syndrome, we recommend baby aspirin with Lovenox or baby aspirin with heparin throughout pregnancy. Um, in my practice with my fertility patients here, if
Yeah.
somebody's had a history of recurrent pregnancy loss and we do treatment, I often will see them, you know, weekly for an ultrasound throughout the first trimester before they go to see their OB for the rest of their pregnancy care. So if you're already in touch with a fertility specialist, you might be able to be seen on a more frequent basis than the average OBGYN office, because we see our patients, for ultrasounds quite often.
That's wonderful. Well, thank you so much for taking the time to do a Q&A, Dr. Van Heisen, for your time and kind of laying all of this out for our community. If anyone is listening and you're interested in getting in touch with Dr. Van Heist and you missed the slide, there's also a link to her practice in the caption where you can contact her and learn more about her background. And of course, if you want to learn more about Lupus LA or see future live expert sessions, subscribe to our YouTube channel or go to our website and join our community, and you'll be notified when we have talks like these.
Thank you so, so much. It was such an honor.
Yeah, thank you. We're really grateful that you could join us today.
All right.